In this presentation, I'll be discussing the Pre-Hospital Trauma Care Education Initiative that's been developed by Dr. Dinesh Vyas and his team at Michigan State University. So just a bit of background information, India suffers from one of the highest trauma mortality rates in the world, and the crux of the problem is the lack of pre-hospital care services. So it's been determined that 80% of trauma patients in the country cannot access medical care within the first hour. There are only a few thousand trained paramedics for a population of 1.2 billion people, and trauma outcomes are worse for rural residents, as a majority of these emergency care services are concentrated in urban areas. Finally, there's a lack of capacity to address mass casualty incidents and natural or man-made disasters, but these are very relevant to the Indian context today. The proposed intervention is a 2-day intensive and hands-on training program that's aimed to maximally engage first responders, and one that's rooted in the local context, or really focuses upon the local issues. First responders have tremendous capacity to improve outcomes for patients as they're acting during the golden period, the 1 hour immediately following a traumatic incident, when patients are most responsive to medical intervention. So bolstering their role can do a significant amount in terms of reducing the burden of trauma mortality. The course content is based upon existing trauma protocols from the Pre-Hospital Trauma Life Support Group as well as the National Highway and Traffic Safety Administration. Ultimately, the goal is to develop an effective, sustainable, and replicable model of education. This initiative has been in development for several years now. Dr. Vyas has done a significant amount of work in terms of understanding the ground situation. He's visited multiple emergency departments across the country. He's also visited multiple simulation centers, including IRCAD in France, which is a leading sim center in the world, but this is an effort to develop the most engaging, high-impact educational program. Finally, he's done a lot of work in mobilizing individuals who lend their support to the cause. The core components of the education program include instruction in the lay and native language, and this is to really connect to and engage with first responders again, who are not necessarily proficient in English or medical practice. High fidelity simulation is one of the most important components of the program, and the reason why is because it allows for technical development of technical skills, but also a level of emotional preparedness and affective preparedness, which are really crucial for working in acute trauma settings. And these are things that can't be fostered through traditional didactic methods. We've also really emphasized collaborative learning and positive reinforcement as important educational principles in facilitating learning. We've put together advanced toolkits, and one of the components is the King LT airway, which is pictured here. And this is to maximize the impact that first responders can have on the field, but we've also ensured to emphasize improvised management. In case first responders don't have access to the tools we provide them, they still must be able to stabilize the patient using commonly available resources. We've incorporated many self-learning videos as an audiovisual component, but also something that helps us transcend the language barrier. Finally, we've incorporated video debriefing as an important evaluation method. So first responders can really benefit from watching themselves go through a task and identifying areas for improvement or areas of strength. In preparing this program, we've developed a variety of aspects of the educational initiative, and this includes, number one, the curriculum. So again, this is based upon pre-existing modules, and we were sure to incorporate a variety of topics ranging from hemorrhage control to fracture stabilization. We've included chest injury management, triage and communication, shock management. So we wanted to incorporate the most essential pre-hospital trauma care management concepts. We also developed a manual that could be an easy reference on the field, and this has been reviewed by a variety of faculty members. We developed interactive lecture sessions, We also developed the procedural component to go along with the didactic component, which are these skill sessions. The main aspect in this was the Lairdell SimMan 3G, which is the high-end simulator that we used in India, and this you can see pictured on the top right. We also developed these toolkits, which had the highly advanced tools, including the King LT Airway and the pulse oximeter, but we also included scissors, a variety of different bandages, surgical tape, gloves, more basic components as well. And then we had to develop consent forms, surveys, and obtain IRB approval. This is an example of a presentation that we put together on airway and breathing management. We conducted the pilot session in Jodhpur, Rajasthan, which is in western India. And this was conducted at AIIMS, Jodhpur. So we collaborated with AIIMS, Jodhpur, Dr. S.N. Medical College, which is another local medical institution, the local police department, and the local administration in implementing this program. So we had support from a variety of different sectors. We trained nearly 50 first responders who came from the police department, the fire brigade, 108 services or the emergency services, taxi drivers, nursing staff and students, and also interested hospital staff. And we recruited 18 instructors to train these individuals. And these instructors were medical students and medical faculty, and also private practice physicians. Participants were divided up into 4 batches of 12 to 13 participants each, and they came in morning and evening sessions, which were 6 hours. So we had 30-minute didactic or interactive discussion sessions, such as the one depicted here, followed by 35 to 40-minute skill sessions. And here you can see first responders learning to insert the King LT Airway. Here, first responders are shown learning to improvise a splint from commonly available resources. We also had a session on IV line placement. Here, first responders are seen learning the log roll maneuver. And here was a session in which first responders learned to improvise tourniquets using a pen and a strip of cloth or a bandage or tourniquet material as depicted here. So the pilot session garnered a significant amount of positive response. The goal now is to transition to phase 2, which is going to involve establishing a self-sustained program in Jodhpur. So right now we are focusing on streamlining funding and streamlining administrative support to the project, and right now AIIMS is in the process of conducting regular monthly sessions for first responders. We're also to continue data collection. We're also looking to continue data collection. Right now we are following up with our participants regarding how often they have used their skills and tools and the outcomes of these interventions, and if there's any interest in further advanced or refresher training courses. We're also looking to further develop the curriculum and course materials. Again, this program is still very much in its preliminary stages, so we're really trying to expand and develop the curriculum course content. And finally, we're looking to develop a multi-center initiative. So in this sense, we have identified 5 collaborating sites, and Dr. Vyas will be visiting 2 of these sites in the next couple of months to run pilot sessions there. This is SMS Jaipur and Kangra Dharamshala in Himachal Pradesh. We're also looking to work with CMC Ludhiana, CMC Vellore, and Apollo Hospital in Hyderabad. Again, covering a wide expanse or wide geographic expanse will allow us to understand how to tailor a program for a particular local context. And this is something that we're really hoping to do so that we can develop a universally applicable and flexible program model. So as of now, the focus is on these phase 2 objectives. so that in the next 3 years we can train 5,000 first responders in each of our 5 collaborating sites. And so this will involve establishing, again, regularly running self-sustainable initiatives in each of these centers. Within 5 years, we'd like to train 300,000 first responders among 50 sites. So this is a long-term, large-scale project, but we're hoping to establish strong centers for excellence that can help us mediate this expansion. Finally, if we can get regular self-sustainable centers going, we can start to begin collecting data regarding the impact on trauma mortality rates. This is something that is on our radar for the long term. Right now, the focus is to develop the educational component. Later on will be to assess the impact of the educational program upon local mortality rates. So essentially, our objectives are to provide enhanced education for first responders. Again, these are first responders are central agents and can really do a lot to reduce the burden of trauma upon a community. Then we're looking to ultimately reduce local mortality rates. We're also, we would really like to identify the salient local factors that shape a trauma epidemic. These may be cultural, social, political, or economic, but this trauma epidemic is a comprehensive issue, and we'd really like to take a comprehensive approach to address this. And finally, our goal is to develop a self-sustainable and replicable model of education that can bring about reductions in mortality across a variety of regions across the developing world. Thank you for your time.